We have really great presenters today. Both are providers for the Movement Disorder Center at Beth Israel, which is also a Parkinson's Foundation Center of Excellence. So both of the speakers are a very integral part of our movement disorders team. So I will pass it over to Linda Della Porta, who is our occupational therapist, and Darlene Harrier, who is our physical therapist. Thank you.
I'm Darlene Harrier.
So I've been here at the Beth Israel Deaconess working in outpatients for over 20 years, and specifically in the Parkinson Center of Excellence for, I believe it's been at least 10 years. So a huge part of my caseload is working with those with Parkinson's. And the, I think, even before we were part of the Parkinson Center of Excellence, I worked with patients with Parkinson's, and I have to say that now with that cohesive center, it's so nice to work with other members of the team, which helps support my work and just helps provide you with the services you need as well.
I'm Linda Della Porta, the occupational therapist, and I'm really excited to be here today. When I first started as an OT in '92, there wasn't a Center for Excellence, and there wasn't this comprehensive approach in looking at Parkinson's condition. And I rarely actually saw people early on in the condition. And I really feel that it makes an impact looking at lifestyle and some of the things that you might be able to control, and to be able to have the best life possible and being able to do the things that you need to do. So in the past, it may have been more of neurologist and medication, but now we're looking at exercise and activity and the impact of that for Parkinson's condition. You dropped my water. It's okay. I'm always drinking water.
Okay. Good, this still works. Okay. So in today's talk, we hope we convey these points, particularly that I think it's important to know when you need a referral to physical therapy or occupational therapy. Sometimes people aren't sure when they should be seen. I will say this, I think that it's, even in somebody who's been recently diagnosed, it's probably the perfect time to start. So at being first diagnosed, at least to assess how you're doing with your exercise. We want to get you on an exercise program right away. But certainly throughout the course of your illness, we're here for you. We can assess and get you started on an exercise program if you haven't been. And actually, because this is a lifelong condition, you should consider us as an integral part of your team in helping you manage the symptoms over time. And of course, we're here to help. Hopefully that you understand by the end of this talk that you'll learn how some difficulties in performing mobility or activities mobility related ADL, that we can help with ways that you can compensate to be able to do those more easily. And then of course understanding how which exercise is helpful in reversing some impairments and even possibly slowing down the rate of progression of the disease. And then the most important is how to keep doing your exercise prescription. I think that's what you think of when you make the most of your PT and OT. So to start with, we thought it would be helpful to explain the difference between physical therapy and occupational therapy, because we do overlap quite a bit. And so we get that question a lot, like, how are you different from occupational therapy? and I'll let Linda explain the OT and I'll explain physical therapy, is the use of physical interventions, not medications, to improve one's function due to a disease or injury. So specifically in Parkinson's disease, because it's a progressive neurodegenerative disorder, very important that you participate in a physical form of exercise throughout the course of your illness.
What is occupational therapy? It's a healthcare profession to help with occupations of life. And that can be anything from your ability to do your self-care, your ability to do the things for work that you need to do, exercise, and leisure. And I like to look at things in a holistic way and kind of focusing on the area that you need most. There's many reasons that you might need or want to see OT or PT. As I mentioned earlier, I rarely saw people early on with Parkinson's disease, and I find that that's really helpful to be able to make a plan and to be able to have a as healthy lifestyle as possible. So if you're newly diagnosed or if you've had the condition for a while, that might be a reason. If you'd like to exercise where you're uncertain what exercises are most optimal for you, that's a great time to see mostly Darlene in terms of developing an exercise program. You might have had other exercises that you really loved and enjoyed doing but are hard for you to do, and maybe finding a way to do those exercises or developing a new program. And obviously, changes in symptoms that come about because of Parkinson's condition might be a reason to see us. There are many things I would look at in an occupational therapy evaluation, and I really tailor it depending on what it is that you need. OT focuses more on hand and upper extremity function and coordination, so I will take a more focused look on that area. While I won't look at your emotional or cognitive status, I definitely take that into consideration because with any life condition and with Parkinson's, depression and anxiety can make it hard to do certain things and being able to tailor your program. And also the wonderful thing is because we're part of an interdisciplinary team, there are other team members that we will work together with to help with your care. I'll also take a look at your environment and making it most optimal if that is an issue. Another thing that if your daily routine is altered, it's helpful to take a look at how your day functions. And that may or may not be the case, but oftentimes I'll ask people to do a schedule from the time you get up in the morning, from the time you go to sleep, and write that down for several days or for a week. And notice the times that you take your medication, but also notice your fatigue level and notice what you do during the day. And that can be helpful too if you're trying to integrate exercise, like finding the most optimal time of the day. If you're having trouble sleeping, what is we call it sleep hygiene. What kind of things do you do to help with relaxation before you go to sleep? So it's really nice to have that information to be able to tweak and be able to incorporate activities. Then, depending on what it is that you indicate is difficult, I will take a more focused look at analyzing the activity. Maybe it's handwriting, maybe it's buttoning, reaching, and grasping. Because of Parkinson's condition, there's underlying rigidity that may make it difficult to do certain tasks, and finding strategies or ways to live with it, or finding a different way of doing things. And there are standardized coordination tests that give valuable information, timed tests for coordination, and I'll compare left and right sides. However, that may change your ability to do these tests depending on the time of day, how you're feeling, and if you are taking medication. But I always like to combine that with seeing how you actually do things. And then there are some objective measurements that I have as well as Darlene in terms of your strength. That is called a dynamometer, so it's a measurement to see how strong you grip and how strong you pinch. And I'll compare your left and right and see if there's a difference, and if that is also something that might be impacting your hand function. And as I mentioned earlier, we'll look at your flexibility and range of motion. If there's tightness and if there's actual joint restrictions that are making it hard for you to move, which can impact your ability to do your daily activities and make it harder for you to put on a shirt or being able to reach and grasp. So I'll look at how things are actually moving and if there's any flexibility and range of motion exercises that we can do to complement that. And that also impacts your posture and alignment. As an OT, I focus on the upper body, but really we both look at everything together. For example, being able to put on your shoes might be impacted if your hips are tight. So finding ways to work on that. Sitting posture. With Parkinson's disease, that contributes to the forward flexion of your body, which can sometimes be hard to maintain throughout the day. So one of the things I'll ask you is about your everyday activities and where you spend your time and how you're seated and your posture and alignment. So I'll ask you when you leave here today to think about the places that you're seated most and noticing if there's anything that can be altered in terms of the position and alignment. If you see here in this picture, his feet are firmly on the floor, his pretty decent support from the chair, and the arms are in a position where it's a little bit easier to type. The monitor is in a place where it's easier to look forward. So that is an example of optimal alignment. And think about electronic devices, which are really amazing, but our iPhones and our iPads, that how much time you spend, and that also can contribute to that forward posture. Because you have, with Parkinson's condition, you have that you're dealing with trying to keep your alignment, but then if you're also spending your time and day in a forward position or not in the best alignment, that can also contribute to tightness, unnecessary tightness, and unnecessary weakness. So can you take a look at how you're sitting right now? All right, your feet on the floor, hip width. Can you try to lengthen your spine up a little bit more? If your head is forward, can you lift it up, place it over your spine? If you're able, can you actually sit maybe a little bit away from the back of the chair? That can also work on your trunk muscles. So if you are sitting, you have a great chair at home where you're typing that has support, that's fabulous. But also at times, kind of to work on your trunk posture, like actually sitting away and sitting upright can be helpful. And noticing too that your breathing and other things are affected when your head is down in that flexed posture. So when you're sitting upright, it's easier to breathe, it's easier to move, and it's easier to do daily activities with your hands, whether it be eating, brushing your teeth, typing, whatever that may be. But Darlene will talk a little bit more about standing posture. It's also important if you are on the computer or if you are writing for a long period of time that you're not in that position for a long time and that you're intermittently getting up and moving.
Okay. So this is very similar ideas or areas that I would evaluate as what Linda mentioned. But as she said, my focus would be more on mobility, how these areas that I would look at relate to your functional mobility, your walking, balance, etc. So I just want to now go through each of these more specifically. So posture tell me so much information about where we need to start. Just as you come in, I'll make note of where you are in terms of alignment. If you're leaning too far forward, I'll know I need to work on improving the strength of your back, or I might need to work on stretching of the muscles in the front. So this just gives me an overall view of where we need to start. So that's one of the first things I look at is posture. Then more specifically, I'll take a look at seeing if you can move out of that posture or if you're stuck in that position. So if we can increase that a little bit, I'll try to see what your limits are and try to work on improving that. But I need to know where where to start with so that I'll be able to prescribe the right exercises. So for example, if you might still have the ability to move out of the forward stooped posture and help you rediscover that you can actually stand up straighter again and then stretch and keep those muscles from getting tight. I should say that the difference between range of motion and flexibility is that the range of motion is what occurs at the joint. You might have full range of motion, but the flexibility of the muscle that crosses the length of an extremity might be too tight, so you don't have the same, the ability to elongate your movements. So I would look at evaluating that to determine whether you need specific exercises to improve your flexibility. Strength is assessed to find out what's, I should say actually, strength isn't specifically affected by Parkinson's, it's what develops, you lose strength as a result of the underlying motor symptoms. Because of the bradykinesia and the rigidity, you don't move as much as you previously did, so you lose the strength by not using the muscles to their fullest. So this is just an example, some examples of how checking your strength functionally. So you might have good strength in holding your arm or leg up, but it's not working for you when you need it during a functional activity. So putting you through activities like see whether you can get up from a chair without using your hands, or how many stairs can you climb in so many seconds is a good way for me to measure strength. Or if you can do push-ups, that's another way I would check strength. So I'm also assessing these underlying motor symptoms which are prevalent or comprise the problems in Parkinson's disease. To be, I'm assessing how impaired are you as a result of these underlying motor symptoms. And I included this also just to give you the terminology to understand some of the definitions of these symptoms. And you might be very familiar with them already, but some of them you may not have been able to understand the difference. Particularly the difference between bradykinesia, hypokinesia, akinesia. And you might have heard bradykinesia is basically the slowness of movement. But within that, hypokinesia can occur is where the amplitude of movement or the amount that you move, even though it might be a slow movement, but the degree to which you move is reduced. And then akinesia refers to the difficulty in initiating movement. And you see that, for example, in initiating gait, starting to walk, or you get stuck, freeze, that's the akinesia. Postural instability is as a result of the imbalance that occurs as a result of the rigidity and bradykinesia that doesn't allow you to respond as quickly as you normally would have to perturbations or balance loss. So that's what postural instability refers to. I included also, I assessed for whether you might be reporting symptoms of dystonia, but you may not call it, you won't call it dystonia. You'll say, I'm having problems with my toes curl, at certain times during the day, or all the time, or I get painful cramps. So, that's as a result of usually under treatment. It's because of the increased rigidity. So that's something that I would evaluate for. And, question?
Do you consider pain to be a primary symptom, or do you consider that to be secondary to other muscle problems?
It's a secondary impairment as a result of these underlying motor symptoms.
There is a school of thought that pain is a primary problem in Parkinson's.
Well, it definitely can be like up front and center in terms of limitations in mobility, yes. But it's not the actual underlying condition as a result of Parkinson's. It's a secondary impairment. And we'll get to that too. But yeah, so dystonia can cause pain because of the constant clenching or posturing of an extremity. And then dyskinesia is, not everybody would experience this, but it can appear, and it's important for me to be aware of that. And basically what that is a increased movement, so too much movement as a result of the medication. It can be so severe that it can knock you off balance, so you can be almost too on, and that's important to be aware of that. And then I would communicate that with your physician, or help you communicate that with your physician. And I should say, actually, there are some tools, online tools, to help you monitor your symptoms or keep track of your symptoms, so that when you see your physician, you can report all of that, and they can help work with your, titrate your medications a little differently to help control those symptoms. So now getting to more of a functional evaluation. Most importantly is how you're moving, how you're walking, how your balance is. So I have specific tests that I would do depending on what level you are functioning. For example, I can test your walking speed, get an idea of where you are at this given time in terms of how you're walking, and be able to track that over time so that I can pick up on any changes that are occurring and be able to intervene effectively. And the same with balance tests. So these are just some examples of various functional tests that we would do to get an objective measure of those functional activities. And then finally, not really finally, but definitely including an evaluation of your activity tolerance by, so the way we do that is taking a pre and post measure of your heart rate, blood pressure, respiratory rate, in response to exercise, so that I would be able to determine what's the right level of exercise to start with, so that we can titrate the right dose of exercise, aerobic exercise in particular. And so actually this is a big part of whether or not, or how successful we can help you be able to carry out exercise. So we assess your readiness to exercise, or try to identify some possible barriers to exercise, because we've found that this is really important, that if you are limited in your participation to exercise, you're not likely to really be as adherent to the exercise, or be totally on board with doing the exercise, even though you hear that you should be doing it, but it's just not working out for you. So we help identify what are some of these barriers. For example, if you have too much pain, we need to assess at what level and what is causing your pain and try to address that first to help you then participate in a more progressive form of exercise. We also recognize that some people may have environmental factors to exercise. They may not have accessibility to a gym or a group exercise that's like really motivating. And some people are really limited in getting out in their neighborhood to walk. So we take that into consideration. And then there's personal factors such as, depression can be very, very disabling just in and of itself. And you might have the physical ability to exercise, but your mind just isn't there. So that's where, if I am aware of this as a limiting factor, I would encourage my patients to be, engage with other members of our interdisciplinary team in psychiatry or social work to help with addressing the depression or anxiety, and then that we work together to try to get you to the right place in terms of exercise. And I have here also self-efficacy is a term that you might have been hearing lately. That's a term that has been given for, and it's a big barrier for a lot of people that they just feel like, why bother? I can't do this. I don't feel like this is really, I can really do this. It's just too much. So, and that's partly because of not really understanding or knowing what exercise can do. So we address that through a lot of education. All right, so this is actually leading into exercise. So the more you know about what benefits exercise can provide, the more likely you are to exercise. So far, I know I mentioned that we think exercise potentially can slow down the rate of progression. The thing is, we don't actually have any human models or human studies yet. I think we're in the preclinical studies where they can actually see some of these results that they've found in animal models in which exercise, particularly aerobic exercise, has been shown to improve the availability of dopamine in the synapses where it's picked up more readily. And then also they found that it has increased the production of these neurotrophic factors, which is necessary for improving or maintaining neural health. So if you think about, so those are the underlying, at the neurologic level or microscopic level of what's happening to the nervous system. So if those things are improving and they can see that perhaps with exercise in the animal models that's slowing down the rate of progression of the Parkinson's, that we hope that that can be the same thing that's happening in humans. Yes, quick question?
How much of this exercise do we need to have per day?
Yes, we're going to get to that. Perfect. I think that's coming up soon. He was asking how much of this exercise do we need to do per day. So that could be an entire talk in and of itself, but...
10% more than you're doing now.
Yeah. So, but we do know, at least at the functional level or behavioral level, that exercise for those with Parkinson's is beneficial in improving I should say even reversing some impairments. In fact, like improving strength, improving range of motion, which leads to improved mobility, and also just overall health-related quality of life is improved as a result of exercise.
And I'd like to say that there's probably hasn't been a ton of research in this area, but it makes sense. I think a lot more research is funded towards medication and other things, but it's exciting that we're looking at this area. And also, we do know that exercise is good also for anxiety and depression, which is a component of Parkinson's condition. And finding a way to get the right exercise that you can do, there's a feedback loop so that we'll seek it more and being able to integrate it.
So the exercise prescription is what we end up with after doing all of this evaluation. And it's very complicated. It's not just, oh yeah, you have Parkinson's, you're going to do this. So, even in the general population, nobody does the same exercise routine. Everybody has their own abilities in terms of where they start. So that's, you should consider the fact that because of the Parkinson's, the limitations from the Parkinson's, we just need to start a little bit differently than you may have done, say, 10 years ago before this all began. So I just list these as the primary areas. These are different types of exercises. Stretching is one type of exercise that in terms of dosing, I'm going to try to allude to that because you asked like how much exercise one should do. Basically, stretching is best done after you've actually done the exercise. You want to have warmed up muscles so that they can stretch more effectively. Strength training is generally done just a couple times, 2 or 3 times a week. You don't need to do it every single day, although if some people like to have a routine and they just say, no, I need to do it every day, that's okay. So as long as you don't overdo it, if you just keep the repetitions low, you could, that's not a problem. But if you're doing, heavy strength training, you can give yourself a break, do it every other day. But the endurance training, the aerobic exercise, that's the thing you need to try to do every day, if possible. Everybody should be doing aerobic exercise every day. And, the general recommendation is 30 minutes a day. And yes, even you can do 30 minutes a day, but you don't have to do it all at once. Say, if you can only tolerate 5 minutes of whatever, cycling, walking, rowing, whatever it is you're using, a machine or not, if you start with 5 minutes and you try to do 5 minutes of that 6 times a day, you've got your 30 minutes. And that there's evidence that that's beneficial as well. And then, of course, balance training that would be specific, prescribed to what your level of balance impairment is, and try to work on that. And then task-specific training, everyone does that. For example, if you want to get better at playing tennis, that's a task-specific training. But in your case, because your walking is what's the most challenging activity and you want to be able to continue walking, that's where I recommend spending a lot of time practicing the actual act of walking. And so it works out nicely if you can combine your aerobic exercise into that activity, because it becomes then, you're killing 2 birds with 1 stone, basically. But if you're not able to walk, if you're not able to walk at that level of aerobic conditioning, then, you keep that separate. But it's still important to work on walking at whatever level you are so that you improve that ability and prevent that from declining. I just want to say that because of the Parkinson's, you lose that automaticity of that normal way of moving. And so you have to put your mind on the activity. So that's the practice in walking. What? Oh, hold on. Yes, we're going to get to that. Yes. We're actually about to talk about freezing. So the question was, does any of this relate to freezing? So that's where strategies come in. So specifically in applying, because of the fact that the brain has lost its ability, in the basal ganglia is not giving the input that is, or output I should say, to support more automatic movements. That's what's limiting your ability to perform responses to loss of balance, or in your ability to walk normally as you did. So that's where we tap into certain strategies to help compensate for that. So Linda's going
to... So as Darlene mentioned, we would tailor the strategies according to what would work for you. And it might be something visual or maybe an auditory cue. Also, it takes a tremendous amount of energy to constantly be thinking about how you move. And that can be fatiguing. So that also plays into the role of looking at your daily schedule. Also, for each particular task, figuring out the cue that works for you and paying attention and using that cue to help you with that task. So I'd like to start with the concept of mindfulness, which is a way of thinking about your strategies. So whatever strategy is working for you, using that and paying attention on purpose. Mindfulness is a concept that was developed by John Kabat-Zinn, and I don't know how many are familiar with it, but it's pretty prevalent right now. This word is used quite a lot. But there is research supporting it for being able to live with and manage life conditions, and also for meditation. And I find it particularly helpful, not just for Parkinson's, but for everything. And being able to have this non-judgmental awareness of the present moment with what you're living with right now. Because our mind is always trying to protect ourselves, and we might think about all the worst possible scenarios of what might happen, and it's really, that takes a tremendous amount of energy away from what we can do right now. And I really like the concept of paying attention on purpose, and that also plays into, with Parkinson's, it's really hard to multitask and having multiple things going on because so much energy is spent on being able to purposefully doing your movements. So I find that this type of training probably would be helpful. I'd like to say that our treatment is flavored with this, but we don't do mindfulness training. That would be a specific meditation technique. And when I was putting this talk together, one of the social workers actually emailed me that they are starting a group on mindfulness meditation. So if you're interested in specifically learning a little bit more, that might be helpful. But I like these two concepts in taking the strategies that you use and paying attention on purpose. And so there are other things that we'll talk about in terms of reducing environmental risk and planning your activities so that you're most on and most active part of the day. Darlene will talk a little bit about assistive devices, and I'll talk about adaptive equipment.
well, so actually before we get into assistive devices, which is actually I should just say that we encourage use of assistive devices when you are faced with, are you not able to walk at all? So, and it's not about thinking that you're becoming dependent on something, but thinking about it as a way to allow you to be more active. So and I know it's a very emotional thing for a lot of people to think that, oh, now I gotta use something to walk with. But I try to make it more of a positive experience in that, well, now this is going to allow you to get out into the community more and be more active. It's going to help prevent you from falling. The last thing you want is to get to that point where you're falling. We got to support you so that you can be active, remain active. The longer we keep you walking, the better. That's the goal. But before this, I want to say that oftentimes we can address these problems in gait simply by, again, remembering the strategies, using the cognitive part of your brain to control where your feet are going. And that I work with a lot is as soon as possible, when we identify freezing is one of the biggest problems that cause falls, is to provide training in how to apply a more cognitive control of your walking. And sometimes that can make the biggest difference right away. But you have to be constantly bringing your mind back to the cognitive control of your walking. And that's where what Linda was talking about is taking time to be mindful. So oftentimes what I try to get people to think about is whenever you are on your feet, you are thinking about walking, not about, oh, I gotta go get some cookies out of the cupboard and get upstairs and take a nap. But to focus on what you're doing at the time. And so normally what occurs in walking is, what you don't realize is that the first thing to hit the ground is the heel of your foot. But until that's broken down for you to realize, it's oftentimes not even part of what is, in your mind. And so you're just getting your feet out. You're thinking, just get my feet out. And what happens is you're hitting the ground with just the front of your foot, and that's what ends up causing you to stall or freeze. But if you think about making every step an intentional step out on the heel and trying to lengthen each time you take a step so that it's longer and keep that going, it will allow you to walk with greater ease and less freezing. And then the other thing is turning around becomes a big problem for so many people if they're suffering from freezing. And of course, we don't think about when we turn, right? We just think we're going to turn around. And we're not thinking about the fact that your feet are not on board with what's happening until you realize they're not on board and you end up falling. So again, the thought is to get your mind on what's happening. What's the first thing to move should be your feet. So you want to always lead with the foot to the side you're turning. That's my catchphrase. So whenever you're turning, always step out with the foot. So one thing I've got thinking about is something called the clock turn strategy. You may have heard of that. That's actually a term that's come out recently, is using the idea of a clock in your position awareness. So if I'm starting at 12 o'clock, facing 12 o'clock, if I want to turn to the right, I want to step out to the right with my right foot and then bring the other one around. So this becomes an exercise. I send you home to work on actually coordinating this, completing a clock in 4 parts, stepping, and then gradually increasing so you do 2 turns, 2 steps to turn. So you break it down into leading with the foot to the side you're turning. So that would help reduce your tendency to freeze and not get your feet moving where you were expecting them to be. I have some of these assistive devices actually here. If you're interested in just seeing what these, the walker was specifically designed for those with Parkinson's, and that includes features that could be added. For example, the fact that it has a very heavy base and it has the ability to slow down the movement if you have problems with festinating gait, which is basically you get going and you can't stop. And it also could be fitted, outfitted with a metronome, for example, to pace your walking, and a laser across the base. So that provides a visual cue to help you keep your mind on stepping out each, like stepping into the laser with each step. So those are some, those are some strategies that people have found helpful. Yeah, oh, okay, well I didn't mention that because I just thought I was going on and on. But so the question was, so how do you keep from falling backwards, which is also a big problem. And that's the reason for that design, is that it has the base of support is actually extended behind you somewhat. And the way it's designed is that if you, I'll demonstrate actually. So that if you're walking within the walker, and if you're backing up and you start to freeze backing up, I am leaning, this is holding me up. The base of support is behind me. And as long as I'm holding on to the walker, this isn't going to let me fall. Yeah, it's like anti-tippers in a wheelchair, she said. That's right. So as soon as if you can, hold yourself in this position, if you're feeling like once you get stable, then you can regain your balance, regain your foot position, and then continue. So that was part of the design of this walker, is to help with various types of walking problems, all built into one device. So this is called the Use-Step Walker, Use-Step Walking Stabilizer. So I have this here in our clinic as to trial. The company sends it here. They send us like updated models when they become available. I think this was a new one from a couple of years ago. This is the outdoor model, and then they have one for indoor use. The wheels are different for indoor and outdoor. But so we can, yeah, and I should say, so another feature, this has so many features I can't even remember them all. So the other feature is that instead of brakes, you have to squeeze the releases to get it to go. So that helps because it allows you to be engaged in the activity of walking, rather than walking along and then realize that you're going so fast that you can't stop. And what happens then is, because if that happens, most people would tend to let go instead of braking. But the other feature is that it has a built-in slowing down mechanism, so we can increase the resistance of the wheels so that they don't roll so easily. So we could make it slow, so you have to kind of push and get it to move. As I mentioned, they could include a metronome if that's a strategy that works for you to keep you taking steps at every regular beat, and a laser that would go across the base of the floor to help you be able to use a visual cue to step. And it has a seat. I think I got all the features now. And it folds. See, if she didn't ask me, I'd probably forget to say that too. So it folds, it comes down. It's just a little complicated. I can do it later, but so we want to keep talking.
So Darlene mentioned assistive devices, and I'll talk a little bit about adaptive equipment. If you look at the picture, the top piece is a leg lifter, so that is something to help if you're having difficulty getting your leg in and out of bed. Then there's a dressing stick, which is helpful for being able to don or put on lower body garments. There's a reacher to help with reaching, long-handled shoehorn, and the thing on the bottom looks like a lollipop is a long-handled sponge. So as an occupational therapist, I always look at how you're able to do the activity before you need to use something like this. For example, with bed mobility, it might be difficult getting yourself in and out of bed. Are there strategies or ways of doing it so that it's easier? And then if the strategies, the stretches, the exercises, and the position doesn't work, then there are devices that can be helpful. Woo! It's all wet. The other aspect that I'll look at is your bathroom setup and making sure that it's safe. And sometimes it would be just having a grab bar in a certain position. Other times having a chair or redesigning how you get in and out can be helpful, because reducing fall risk so that you don't have secondary injuries is very important. And the bathroom area is an area where is a high fall risk, regardless, slippery. So I look at the bathroom area, but I also like to consider other environments. Where do you spend your time most? Your work, your office, your home. And to make it as accessible and easy to use as possible. Removing any throw rugs, any obstacles, making it big and spacious. And also thinking about the ambiance of the room. If it is your bedroom and place where you need to sleep, being sure that the lighting is just right and that it's off when you go to sleep, that even things like your clock, the light from the clock can be something that could keep you up. Thinking about removing television or iPad, if that's what you use at night, just to help with sleep. The office environment or the kitchen, going in and super organizing. Removing and reducing any clutter, organizing areas, because as we keep mentioning, there's so much effort going into kind of moving and doing your cognitive tasks that having your area of work and play be as organized as possible will be helpful. So I look at it from the safety perspective, but also from a functional perspective. And this is something that we can all use to be able to function more effectively. One of the aspects that can be most difficult is handwriting. And I wish I had the magic solution, but I don't. But there are some strategies that can be helpful. Very similar to some of the things that Darlene spoke about, using the visual strategies. Sometimes lined paper can be helpful because you have that visual cue. The other aspect, which Darlene also uses with walking, is thinking big. With handwriting, exaggerating your handwriting so that the letters are bigger. The type of pen that you use can be helpful, making sure that it's thick and easy to hold on to. And then integrating all the other concepts we spoke about is making sure you have a good seated environment, good support, so that handwriting is easier. And reducing multitasking. Because you're using that cognitive skill for handwriting, that having a lot of outside distractions can take away from using that strategy of thinking big or writing big. So that would be the strategy would be to think big for writing, and that's also kind of a component of mindfulness, is using that, really focusing on that aspect. So care partners, it's with Parkinson's disease, and with any condition, it's the whole family, friends, everybody that's affected, and how we can all work together in being able to optimize health and function. And you may have been the one totally in charge before, but being okay with having help when you need to, that's really hard. So as a team here, we really look at not just you, but everybody that's involved in your care. And if there are strategies and things that we find helpful, to be able to have family members or people that are close by you also be able to help you. Especially if it's an external strategy. Sometimes it might be helpful, like I mentioned earlier about your sitting posture. Maybe have somebody take a look at you today when you go home and all the different places that you sit and see if there's anything that can be adjusted. Because that internal sense might be lost a little bit, and that can be helpful to have the visual cue. So maintaining an active lifestyle. This is kind of the overarching thing. And this is why I'm excited that both OT and PT can be involved early on. It's about taking a look at your whole life and how you can have more exercise or activity and be able to do it in a way that's reasonable. Because it can be really stressful to think, oh gosh, I need to exercise, but not have a way of doing it. And finding, I spoke about the schedule earlier, finding a realistic way to schedule and make it a routine. It might be something like doing it twice a week at a certain time, and do that for 2 or 3 weeks until it becomes a habit, and then it won't be so painful to go exercise. And then once you get the feedback loop from the dopamine and feeling better from exercise, it's easier to keep up with that. I also feel that having a group, or, sorry, I went to your email here, a group is much easier, or having a exercise buddy, or having somebody that you can go for walks with. There's something that's really empowering about that. And also being with other people that have your condition, so having that support.
Oh, I was just thinking too about the idea that, yeah, so sometimes you're not going to remain quite as adherent to your exercises you had planned after you finished your little episode of therapy, and you say, yes, I'm going to keep doing my exercises, but you just, like, they somehow drift away. But it's okay. Don't get too down on yourself. Just say, all right, I'm going to, like, just start back a little at a time, or, full force, whatever. And just don't be too down on yourself. Just get back to it. But if you feel like you need more guidance, again, so it's been too long, you forget what you're supposed to be doing, it's probably time to be re-referred to your physical therapy or occupational therapy. And actually, you should be seeing us every so often throughout the course of your illness, because as you change, so do your needs change. And just like you see your neurologist every, 3 months, 6 months, that might be also a way to check in with the therapist. Every 6 months is a reasonable period of time to reassess your exercise program and see if it's still working for you. Maybe there's some changes that need to be done to help get you motivated to keep doing the exercises.
How many visits does Medicare allow for OT and PT and speech?
How many visits does Medicare allow? We don't even pay attention to that, but we find that what's needed, so what's medically necessary, it depends on each person. So the typical number of visits I might see somebody for to get them started in an exercise program might be anywhere from, say, 4 to 8 visits to start with, and then from there it's like every few months, might be every 6 months, maybe intermittently it might be more again. So it depends on where they are. So I don't pay attention to what the limitation is.
I also would like to say that I feel that our role is as a guide or a consult, and so you may be coming in and we will help you develop the program, but it's not as if you're coming in for a really prolonged period of time. So I often find that there is enough visits. I find it more challenging for somebody who has had a new injury that will require a lot of visits. But usually we spread them out, and I feel it as like a relationship, a consult.
So it's like we're a consult service, so that we give you the tools you need to be able to continue and manage this with support. So it's up to, because this is something you are going to do for the rest of your life, every day, ideally exercising.
Does Medicare allow, how many pieces of equipment does Medicare allow?
Okay, and the question is that she's asking how many pieces of equipment does Medicare allow? Yes, here's the thing with Medicare, they Depends on whether you've had a similar device prescribed recently, so a walker. If you've had a walker that they've paid for within the last 5 years, and you now need a different kind of walker, it's possible to get them to cover that, but it's based on your medical need at the time. So then we'd have to arrange for a letter of medical necessity. They have to review it. They may or may not cover it, so it's more complicated. And besides, that particular walker is, it's not your regular run-of-the-mill walker. So in fact, it does need a letter of medical necessity, and then they would cover, from what I understand, 80%. They cover 80% of anything if they're going to approve it. So it's not very straightforward, but yeah, you have to make that consideration too, like what type of, like how much would they cover. So
I'd also like to add that there are many group activities that are various ways of exercising and doing different activities. And I really like the idea of having other options, finding that being in a group for myself is a lot easier to exercise. But we fortunately do have some groups here that are specifically for people with Parkinson's, but there are groups out in the community that also do the same thing, or that may or may not be appropriate for you, and that's where Darlene and I can guide you. We talked a little bit about mindfulness, and yoga and Tai Chi are very mindful type of exercises because you're paying attention to your body, your movement, your breath. So you are getting that mindfulness through the exercise. And I also would like to add that whatever exercises we give you can be mindful, simply by paying attention to your breath, your posture, and alignment, and doing it in a way that there's not a lot of outside distractions.
think of it as your self-care time. So time you're dedicating to yourself and being good to yourself.
And there's other groups too, the drumming, and we don't have singing here, but I also would like to encourage you, if voice is an issue, sometimes being a part of a group where you're able to sing. I had a person with Parkinson's who was part of a meditation group, and it was Hindu chanting, and that was part of his cultural spiritual practice. And so how amazing. So he's able to do the meditation and also work on his voice at the same time. And being part of a group has that external stimulation. We talk about the visual and the auditory stimulation, how that can be helpful with singing, with drumming. So you have other people and you get that sound so you can get into the rhythm with them. So I think it's really amazing and another way to make it easier to do these type of things. So I'm really interested in a lot of the mind-body treatments and incorporating that within OT and PT. So if you're interested, we have groups here, but like I said, if you're someplace that's not so close or easily accessible, finding a way to do these type of exercises. Or things that you really enjoy, like fishing or being outdoors, so important. And we talk about exercise, but everyday activities that you enjoy and finding a way to do that.